Hi, I'm Rich Vogel. I'm a board-certified neurophysiologist and co-chair and co-founder of the section on intraoperative neurophysiologic monitoring. If you're one of our regular listeners, you know that this podcast is a series about neuromonitoring, and it covers a wide range of educational topics. You also know that I typically do this podcast with my partner in crime, Dr. Adam Doan. But this year, this season, we're changing things up a little bit, and we're doing some interviews with our colleagues who are experts and also share our interest in advancing global spine care. So today I'm joined by Dr. John Ney. John is a board-certified neurologist and clinical neurophysiologist with research interests in comparative effectiveness, outcomes research, and health economics. He's involved in active clinical trials which utilize patient-reported metrics and has published economic decision models, systematic reviews, and meta-analyses. We can count neuromonitoring among his many clinical interests. John and I serve together on the board of directors for the American Society of Neurophysiologic Monitoring, and we're both founding members of the NAS section on intraoperative neuromonitoring. John, it's great to have you here with us today.
Thanks, Rich. It's great to be here.
So you might not be aware of this, but Adam and I actually laid the foundation for this discussion in one of our episodes this season of this podcast, in which we were talking about challenges associated with estimating the number of spine surgeries that are monitored in the US each year. And we mentioned just kind of in passing that it would be misleading to rely on administrative data to make such an estimation. And in the interest of foreshadowing, we said, well, we're going to be talking to Dr. John Ney in a few months, and we can talk more about this. So the goal today is to dive a little bit deeper into administrative data. So when we talk about that concept, let's just go back to the basics. What are administrative data?
Right. So every hospitalization, really every time a patient is touched by healthcare, there's data that's created, and that data can be clinical data, but there's also administrative data that's created for billing purposes and data that's reported to government agencies. And administrative data generally has very little in the way of actually direct clinical evaluation or knowledge that's translated into it. It's really data that is coded for diagnoses, coded for particular either surgeries or other procedures. And the point of administrative data to a large degree is to create a record so that a hospital or a company can bill the appropriate third-party payer, and that any services that are provided are reimbursed appropriately. So that's generally what administrative data is. So just think of it, it's not through chart review, it's through coding. It's usually done by professional coders and sometimes by physicians or other providers. And usually it doesn't correlate super well with what actually happened during the event or the procedure. And it may not be very granular, but it's often the best that we have, especially when we're looking at issues where you have a need for a very large sample size that would be impossible to try to figure out through chart review, that it would require an army of chart reviewers to get through enough sample to really settle any clinical question.
So you mentioned the very large sample size. What are the other benefits to using administrative data for research purposes?
So, if you were to compare versus a randomized clinical trial, RCTs are exceedingly expensive. You have to recruit patients. They're done prospectively. Administrative data is always collected. It is available. It is relatively cheap. In some cases, it is free, but there are insurers who bundle their data sets and they sell those to health services researchers and other providers and for analysis. And generally, you're talking orders of magnitude less in terms of expense compared to a randomized clinical trial.
And if we're looking at a administrative data or study that uses administrative data, what are we looking for in that study?
Right. So you want to see that the population of interest is appropriately identified. So in the case of intraoperative monitoring, we think about if we're looking at spine surgeries, we want to make sure that these were actually the surgeries that were done and that we're not misidentifying patients. Likewise, you want to make sure that your intervention or your exposure of interest, usually for our purposes, intraoperative monitoring, is identified correctly. And it sounds like it should be relatively easy to do, but sometimes it isn't. And often, because the codes are maybe inconsistently reported and there may be disincentives for reporting some codes, then there may be more IOM that's actually happening than what's reported, and that can be an issue as well. So, and then you want to find an appropriate outcome that can be answered by the data that is available. And there are some data sets where it's really just a single episode of care. So, say an inpatient hospitalization, and all that you have is the beginning of the hospitalization, everything that happened during the hospitalization, and then the end of the hospitalization. You don't know anything that happened prior to that. You don't know anything that happened after that. You have to rely on administrative coding to assume that that things that occurred during the hospitalization actually did occur there and were reported correctly, as opposed to existing prior to admission. And you don't know what happened after the discharge. So, some of the more important outcomes that we may see in IOM may not even be realized until after the patient is let go from the hospital.
Interesting. So just diving a little bit deeper in terms of how neuromonitoring is identified or evaluated in spine surgery, how is that done using administrative claim studies?
Right. So there are two major coding systems that are utilized to identify procedures. And in the inpatient setting, it's largely done through ICD, or International Classification of Disease, procedural coding. And in ICD-9, so prior to 2015, there was only one code for intraoperative monitoring, and that covered everything, including SSEPs, MEPs, EMG, and any other codes that would be utilized, or any other modalities. And to that degree, it was not very granular. It didn't say how long the patient was monitored for. It didn't say if there was a portion of the procedure that was being monitored or the entire procedure. So you don't really know the timing of it. And with some of the data sets, you just know that it happened sometime during the hospitalization. So it may not have even necessarily happened with a spine procedure. There may have been another procedure for which intraoperative monitoring was done.
Yeah, and it sounds like it's a lot of possibility for confounding variables to emerge in these studies. So how do you deal with those?
So you make the best of what you have. So again, you're reliant on coding. Often there is at least age and gender information. Some of the additional coding that may be available may allow you to come up with a risk adjustment score. There's a adjustment score called a Charlson, which takes a variety of medical conditions and then compresses them into a single score to allow you to compare patients who are similar in their levels of illness overall in their generalized health. There's an Elixhauser score, which does a very similar thing, is more utilized on an inpatient than an outpatient basis. So you want to take patients who had similar procedures, who ideally are going to have similar degrees of comorbidity, also adjust for age, adjust for gender, and any other procedures that were done on them at the same time, and any other relevant diagnoses.
So thinking about how administrative data have been used in spine surgery for neuromonitoring thus far, whatever available studies have been published, what have they shown?
So it's a pretty mixed bag that's been out there thus far. So one of the first studies that came out that used large-scale administrative data was the Cole et al. Study, which used Truven Market Scan and looked at a number of different procedures, and it used a methodology referred to as propensity score matching, where you're trying to determine the latent tendency of the intervention occurring, and then use that as a way of pseudo randomizing your two groups, those who got IOM and those who didn't. So it's a way of attempting to control for selection bias. And then the matching part, because in this particular study and in most studies, IOM is reported in the minority of cases. They matched on several parts to one matching algorithm, but managed also to remove a lot of the sample through matching, which again is not ideal if the goal is to increase your sample size so that you can try to figure out what happens with outcomes that are relatively uncommon.
Mhm.
So. So that was one. There have been multiple studies since that time, and I'd be happy to elaborate on those if you'd like.
Yeah, I mean, let's jump into one or two. So, I think we're aware of studies that have used, say, Humana claims database like Pearl Diver, which maybe you could talk about the benefits and limitations of using something like that, and what conclusions might be drawn from that type of a study.
Right. So the Pearl Diver data set is reliant on Medicare and Medicare Advantage data, which is all fine and good, but it's largely an over 65 population. And if you look at the average person who's receiving, say, an anterior cervical discectomy and fusion, it's a 50-year-old male, so somebody who's actually working age. So, you're already dealing with a population that may be kind of older and sicker and have other comorbidities than a typical population who's otherwise going to receive spine surgery and or IOM. So it's a bit problematic from that vantage point. They used current procedure terminology coding. They didn't actually use a direct code for IOM or IONM. So there are time-based CPT codes for IOM, and those were not used. They used the baseline modalities for SSAP and MEP and EMG, and looked at, I believe, anterior cervical, posterior lumbar fusions, and I think there was another thoracolumbar study that was done, and again, they're using a methodology that tended to limit the sample size. They might not have correctly identified whether or not IOM actually occurred, and they're doing it in a population that may or may not be representative. So each of these
the claims or the database, it reports what was actually paid. So neuromonitoring was reimbursed. But any monitoring that occurred that was not reimbursed, which is a fair amount of neuromonitoring, would not have been included in that study. Is that correct?
So that's correct. And, also because they're just looking at the baseline modalities, they didn't actually verify whether those modalities occurred in the context of neuromonitoring. So for example, somebody who got billed for an EMG during a hospitalization would be included in this data set if they received the appropriate spine surgery, whether or not the EMG was actually done during the operation itself.
Right.
So it was a little bit problematic. And then, the title of it kind of, of these three papers essentially, wrote themselves, which is, use of IOM in, insert surgery type X, is questionable. And, essentially that they either did not find a significant difference in the neurological complications that occurred for patients in IOM versus non-IOM groups, or that it wasn't significant enough to reach a p-value of 0.05 or less.
Right, and I guess the secondary argument was that neuromonitoring is actually declining in use when it's actually declining in reimbursement. I guess that leads into the limitations of using administrative claims in general. Just kind of high level, what are the major limitations that we think about?
Right. So again, it's not chart review. You're not verifying absolutely whether IOM occurred, and there's disincentive for reporting IOM in some cases, and that may be just by virtue of how the intraoperative monitoring time-based codes are reported and required to so that there's no simultaneous monitoring or presumption of no simultaneous monitoring for reimbursement purposes. So it's certainly possible, and I suspect that the majority of monitoring that occurs in the United States is done under the supervision of a physician who's watching more than one case at a time. Now, how that individual gets reimbursed, I think, is a little bit problematic in terms of representation of what is actually happening in multiple surgeries. So I think that's a big issue.
Yeah. And last question for you, just to kind of wrap this up, but thinking about moving forward, what are some future steps in terms of administrative data and neuromonitoring?
Well, so I think ideally we need more longitudinal studies. We need more studies that look 6 months prior to when the surgery occurred to 1 year out from when the surgery occurred. So one example of that kind of study is one that I did with an economist at Stanford. It got published in 2015 and was on single level cervical surgeries, and showed that even though there was about $1,200 of incurred cost during the hospitalization, that in the subsequent year, those individuals who received intraoperative monitoring were actually saved a total of $380 compared to those who didn't. That includes the hospitalization related difference in costs as well. So in addition to the fact that they had fewer neurological complications, they were less likely to be on opiates at 1 year compared to those who didn't receive IOM. So, it suggests that at least when you take a longer look, that the benefits of IOM are not just confined to the hospitalization itself, but can extend far beyond it. And, that there are other issues with regards to things like quality of life that largely we're not measuring, and that ideally we should be. So that's one thing. I think another is, if IOM is occurring in less than 50% of spine surgeries, then there may be an argument for potentially at some point doing a form of pragmatic randomized controlled trial so that you can see whether or not IOM is actually effective. You can determine whether IOM was actually done. You can do it in a prospective fashion. You can use all the same monitoring modalities so that you reduce the heterogeneity of every study that's done, and you can make it highly granular. So I think ultimately that's something that should be done. I don't know if it will be, because like anything else, it costs money to do an RCT, and it may cost in the tens of millions of dollars to get in a large enough sample size to show that IOM really makes a substantial difference if neurological complication rates are 1% or less.
Agreed. Well, something for the audience to think about. We certainly have a lot of people in NASS who have an interest in determining whether or not neuromonitoring for various procedures is both useful and valuable. So, Dr. John Ney, thank you so much for joining us and sharing your expertise. And to the rest of the audience, we'll be back next month with another interview. So thanks for tuning in.
Okay. It's been a pleasure. Thank you.